The following podcast is part of a certified educational activity titled Biologic Therapy for CRSwNP, exploring the advanced practice provider's role in patient care. Access the entire activity and complete the post-test at peerview.com/NFR860. Downloadable slides and practice aids are also available.
Welcome, everybody. We're going to get started. So whether you are here in person or you're joining us online, I want to thank everybody for coming and attending. And we are going to get started with our session on biologic therapy for chronic sinusitis with nasal polyposis, exploring the advanced practice provider's role in patient care. So I'll introduce myself briefly. My name is Christine Franzese. I'm going to be the chair for this session. I'll have our other panelists introduce themselves really quick.
Hi, I'm Jillian Bensko. I'm a physician assistant at Brigham and Women's in Boston.
And I'm Anju Peters. I'm an allergist at Northwestern University in Chicago. Happy to be here.
And I'm an ENT, and I'm at the University of Missouri. So our goals for today: improve your ability to recognize the signs, symptoms, and impact of chronic sinusitis with nasal polyposis, equip you with different strategies for helping determine which patients would be best suited for monoclonal antibody therapy, provide guidance on the use of these targeted therapies, and enhance your ability to monitor their response. When do you know if they're working, and when do we start and stop them? So I will turn this over now to Dr. Peters.
Thank you very much. So my part today is to help you guys with which patients with CRS with nasal polyps or chronic rhinosinusitis with nasal polyps are candidates for targeted treatment. So what is chronic rhinosinusitis? I'm sure many of you see patients with CRS or chronic rhinosinusitis. It is an inflammatory condition with multiple phenotypes. For chronic rhinosinusitis to be present, individuals have to have symptoms as well as inflammation. Inflammation is key by objective evidence. So the symptoms are classic: nasal congestion, drainage, facial pain or pressure, and decreased sense of smell. For patients with nasal polyps, the congestion and decreased or loss of smell are the main symptoms. And the objective evidence of inflammation can either be seen by endoscopy, where you may see drainage, edema, or the presence of polyps, or by a sinus CT scan, where you'll see inflammation in the paranasal sinuses. We do know that about 10 to 14% of the adults in the United States would meet symptom criteria for CRS. Typical patient presents in their late 30s to about 60s for nasal polyps. Nasal polyps are more common in men than in women, but there is some evidence to suggest that women have it more severe. Potential risk factor for the development of CRS include asthma. We at Northwestern have shown that if you get diagnosed with CRS, the following year you have higher likelihood of being diagnosed with asthma. Getting older and obesity are other risk factors. The most common comorbidities, so this is where CRS really impacts patients because it occurs hand in hand with asthma. Asthma can be present in 30 to 50 to 70% of patients with CRS, more so in those with nasal polyps. Allergic rhinitis is present in 50 to 70% of CRS. And then non-steroidal exacerbated respiratory disease, or NERD, as they call it in Europe. We in America don't. We call it AERD, which is aspirin exacerbated respiratory disease, is a common comorbidity of CRS, or goes together with nasal polyps. These are individuals who have nasal polyps, and if they were to take aspirin or another non-steroidal, will have worsening of their sinus symptoms, worsening of their lungs, sometimes severe enough to need to go to the ER. Other things that trigger CRS, classic CRS exacerbations, are from viruses, sometimes allergens, and again, non-steroidals in a subgroup of patients. So we said you have to have symptoms and you have to have objective evidence of inflammation. Here you can see a CT scan. I'm sure you guys are as familiar as me. Here's the maxillary sinuses are all gray. This mucosal inflammation present. It should be all black. In the ethmoids as well as in the frontals, here's your eyes, here's your brain. Here you can see polyps with mucinous debris, and here you can see polyps with pus present. So evidence either by CT scan or by endoscopy. As you can imagine, CRS has significant impact on quality of life. In the left-hand side, in this study, what they looked at was SF36, and they looked at in normal population in dark blue and patients with CRS with nasal polyps in orange. And SF36 is a way of looking at quality of life, and when they looked at physical component summary or mental component summary, lower score suggests worse quality of life, and you can see patients with nasal polyps have worse quality of life. And then when you look at it with comorbidities, blue again is population norm, orange is CRS without asthma, green is CRS with asthma, and purple is the AERD or NERD, the worst type of polyps that you can imagine. You could see quality of life, whether it be physical component or mental component, goes down in those with nasal polyps, even more in those who have CRS with asthma, and even more with those with AERD. In addition, we know patients with CRS with nasal polyps, and you can imagine it. If you have large polyps, you can't breathe through your nose. You can imagine how hard it would be to sleep. Remember this, you'll thank me later. In this study from Italy, they showed that patients with nasal polyps, 24% had excessive daytime sleepiness, almost 80% had insomnia, and over 90% had altered sleep quality. So poor sleep goes hand in hand with nasal polyps. Now that we know CRSwNP, comorbidities associated with it, worse quality of life, how it presents, how do we treat it? So the bottom line to treat, standard of care, would be topical steroids. There are many different ways of giving it. Many patients use saline rinses, and topical steroids could be over-the-counter nose sprays or exhalation delivery system with fluticasone, which gets in deeper. It's approved for CRS. Steroid stents can be placed in the OR in the office, and then drops or large volume irrigation is another way of delivering steroids, but this is standard of care. Often these patients get antibiotics. However, we have very poor evidence that antibiotics help these patients unless they have superinfected infection. In fact, no antibiotic is approved for CRS with nasal polyps. Leukotriene antagonists, leukotrienes cause inflammation, leukotriene antagonists help a subgroup of patients, especially those with AERD. And then we give them short courses of systemic steroids when the inflammation is very severe, knowing that the more steroids we give, the more likely of increased risk of adverse effects. Many of them have asthma, so you have to remember they get steroids in many different places. So if medical therapy doesn't work, that's when I would send them over to my surgery colleagues. And this is, again, shared decision-making where surgeons speak to these patients with polyps. And you could decrease inflammatory load by removing the polyps. The rinses will get there better into the sinus cavity. But it's important to remember, it's a chronic condition. So these patients then need to stay on some medical therapy. However, in many of these patients, surgery is not the cure. Polyps can come back in 10 to 40% of people, especially those with asthma, especially those with AERD. If surgery is done with newer techniques, the risk of recurrence is lower. But we do know, especially in nasal polyp patients, the more type 2 inflammation they have, which we can easily check by blood eosinophils, or you could check it in the biopsy if they've had surgery, not biopsy, during their surgical tissue, if you see high eosinophils, their likelihood of recurrence is higher. Now let's talk a little bit about pathophysiology. This is one of my favorite figures that actually originally came out from Katie Halsey, who was a PhD at Northwestern, and then we modified it. So when we think of nasal polyps, and you think of asthma the same way, it's characterized by type 2 inflammation. Here is the airway lining, It's faced by viruses, proteases, for example, are present in dust mites, pollutants, allergen. The epithelium, when it's faced by these, the barrier gets broken, and epithelium is also an inflammatory organ. It releases these type 2 inducers or alarmins called IL-25, IL-33, and TSLP. These have been shown to be high in nasal polyp tissue. These then activate these ILC2 cells, mast cells get activated, Th2 cells get activated. These then lead to release of all these cytokines, the classic type 2 cytokines, 4, 5, and 13. IL-4 and IL-13 play a role in IgE production, the allergic antibody which sits on mast cells and degranulates mast cells. IL-5 is the growth factor, survival factor for eosinophils, gets the eosinophils from bone marrow to nasal polyps or lungs. IL-13 is important for mucus secretion, airway remodeling in asthma, and also barrier dysfunction, which underlies a lot of the CRSwNP pathophysiology. So now that we're all experts in this is research done from Northwestern, where my colleague Whitney and I went through charts, and what we found is, here red is all type 2. You could see there are some people who have type 1, type 3. Type 1 is more interferon gamma, antiviral. Type 3 is more neutrophilic, but type 2 is red. Let's just focus here. 87% of US nasal polyps from Chicago, and that's similar all over US, are type 2. 18% have type 3, 17% have type 1, but majority of nasal polyps is type 2. And this then impacts how we treat people. Going back to that same figure, omalizumab targets IgE, dupilumab targets IL-4 and IL-13, mepolizumab targets IL-5. All three of these are now approved for nasal polyps in the US. All three are also approved for asthma, and there are other biologics approved for asthma. There are others that are going to come out for nasal polyps. Dupilumab is approved for many other conditions. It's approved for ages 12 and older for nasal polyps, younger for other conditions. Omalizumab is our oldest monoclonal antibody, and it's approved for 18 years and older for polyps. And Mepo is approved for 18 years and older in polyps. And you could see that they're all approved for other conditions too. So when we think of patients with nasal polyps presenting to our clinics, this is an algorithm that was published a few years ago. It's going to be revised. First of all, you establish the diagnosis, initial management. You figure out symptoms, quality of life, comorbid conditions, get objective evidence of disease, start with intranasal steroids, possibly a short course of oral steroids, see how they do at follow-up at 4 to 6 weeks. If they still have symptoms, consider doing further workup to see if they have type 2 inflammation or how they should be treated. Do they have asthma? Check CBC with DIF. Consider doing a total IgE. Make sure you get either a good history of aspirin sensitivity, or you can even do an aspirin challenge to diagnose. Then you may try giving them a different type of steroid delivery, for example, EDS fluticasone, maybe another course of short steroid, and then see how they do. If they're still not doing well, and that would be many of these patients may consider surgery. Remember, they need to be treated chronically. If they recur despite surgery, this is where considering other treatment options such as biologics would be worthwhile. All the while, I am a part of a joint sinus center where I work with an ENT. We work very closely with our pulmonologists also. If they still don't do well, like I said, biologics. In some people, if they didn't have enough surgery, revision surgery, you could consider aspirin desensitization for the subset that has AERD. However, more and more, we're going towards biologics. And rarely, again, you'd give them short course of steroids. Now, some people, if they cannot get surgery, if they have very poorly controlled asthma or AERD, these are people who tend to recur, or they don't want surgery, it's all shared decision-making, you may consider biologic therapy before or even instead of surgery, or with surgery. Many of our AERD people need both. With that, I'll pass it on to Jillian.
Thank you, Dr. Peters. So I am going to introduce a real-world example of a patient of mine, our friend Rose, who will help us kind of visualize this management algorithm in practice with a real-world example. So this is our friend Rose, who is a 26-year-old woman when I first met her, but prior to meeting her, she tells me that she had, around 24 years old, she suddenly developed this really bad cold that everyone in her house got sick, but for whatever reason, hers never seemed to go away and just lingered around while everyone else seemed to get better. And while she lingered with this persistent nasal congestion, she also started to notice that her sense of smell seemed to not be quite the same anymore. And that progressively worsened until her 25th birthday, where then she also started to notice that she was having some difficulty breathing. And this was new and suddenly out of nowhere. There was no history of childhood asthma. This was seemingly out of nowhere. And this also coincided with this continued nasal congestion. And now this loss of sense of smell progressed to the point where she couldn't taste, and the only odors that were still remaining were not so pleasant. So really strong, pungent odors like skunk, trash. Maybe if she was lucky, sometimes she could smell coffee in the morning, but that was occasionally. And ultimately, her breathing difficulties progressed to the point of an ICU admission for an asthma exacerbation. Now, these frequent episodes of shortness of breath, the wheezing and cough, she ultimately was diagnosed with asthma and started on a combination maintenance inhaler. And she was still, at that time, using her rescue inhaler multiple times a week. She was also started on Zyflow. She was using intranasal steroid sprays to try and regain this sense of smell with little to no improvement. She was also started on an antihistamine in case there was an allergy component. And she ultimately sought evaluation with ENT because she had no sense of smell and couldn't breathe through her nose at this point. And she was found to be full of polyps. This was on both endoscopy and also on CT imaging, as we can see right here. She had quite marked opacification of the sinuses. And she underwent her first surgery at that time and felt dramatically better. She felt like this had changed her life. She could finally breathe through her nose again, but unfortunately, at her 6-month follow-up, she was found to have polyps in her nose again. And that breathing difficulty started to come back as well. And then when I met her, this is where she comes to see me, it was after she had taken 2 tablets of ibuprofen, and she ultimately had to go to the emergency room because 2 hours after, she was having a really hard time breathing to the point where she needed IV steroids. Her rescue inhaler wasn't working to help her breathe, and she really couldn't seem to get control of it until she went to the ER and got those IV steroids. This is where we met, me and Allergy, where we did a formal oral aspirin challenge to confirm a formal diagnosis of aspirin-exacerbated respiratory disease before she was returning for her second polyp surgery. Now, she went for her second polyp surgery, after which we did an aspirin desensitization. The pathology from surgery showed significant eosinophils. They also did a bronchial lavage at that time, which showed marked eosinophilia as well. And even though she was very diligent with intranasal steroids post-operatively, she was taking her aspirin very consistently to maintain that level of desensitization. Unfortunately, we started to notice some things creeping back in, where 3 months after her surgery, she was seen at the ER again for an asthma exacerbation. Her ACT score, when I saw her 6 months after, was 8. She had gotten 3 rounds of oral corticosteroids between the time of surgery and that 6-month follow-up with me, and her FEV1 had dropped to 60% of predicted. Now, this was a 26-year-old woman with a 60% of predicted FEV1. This was not ideal. Her CT scan was also not looking too pretty, and her peripheral eosinophil count was quite impressive as well. At the time that we were treating her, and we'll revisit our friend Rose later to kind of see what steps we take, but I want you to think about kind of how we would be considering treatment moving forward for her when we're kind of seeing the limitations of traditional treatment therapies and kind of what might be promising on the horizon for her for more targeted interventions. But at the time that before we started thinking ahead, she was on Zyflo, beclomethasone. She was finishing up a prednisone taper at that time and still had no sense of smell, even with prednisone on board. She had Allegra on board, aspirin, and was using her rescue inhaler almost daily.
So in terms of this patient, we talked about how you would recognize these patients, and your patient, Jillian, obviously has very severe disease, especially aspirin-exacerbated respiratory disease, and she's had 2 surgeries, as I mentioned, type 2 inflammation, eosinophilia in her blood, and you could even had it in her tissue. So then this is the kind of person that we definitely think should be on a biologic. Now, this is a table from Euphoria. Euphoria is a not-for-profit organization in Europe. It's made out of mostly ENTs, some pulmonologists. There are 2 or 3 of us from US that are part of it. And they came out with this table, which I think is a good enough guideline for us, although in US we don't have to strictly follow this. So they suggested that you'd consider a biologic in someone with nasal polyps who has presence of bilateral polyps, who's had surgery before. So according to European colleagues, they've had to have had surgery, bilateral polyps, because if you see one unilateral polyp, you have to think of other things, including malignancies, even though they're rare. I will tell you, we saw someone 2-3 years ago on one side looked like a polyp. I sent her to my colleague, Kevin Welch. It was actually a mucosal melanoma. I saw that woman in 2019, 6 years ago. She just got admitted last week. I was on call to our ICU with angioedema and other stuff, and thank goodness I had sent her to Kevin. But so according to Euphoria, you should have bilateral polyps who've had surgery, and then 3 criteria of the ones listed: evidence of type 2 inflammation, which makes sense because these drugs target type 2 inflammation. How do you tell type 2 inflammation? Either tissue eosinophils greater than 10 per high power field in someone who's had surgery, blood eosinophils greater than 150, or total IgE, the allergic antibody, greater than 100. They could have need for systemic steroids or contraindication to systemic steroids. And this, again, by consensus, is 2 or more per year of steroids, or if they're on long-term low-dose oral steroids. And very rarely do we ever see this anymore. We used to see this prior to biologics, where they were steroid-dependent, often asthmatics. They should have significant impairment of quality of life, and one way to assess that is by SNOT-22, or sinonasal outcome test, our favorite way of checking quality of life in the sinuses. Greater than 40, greater than or equal to 40, loss of smell, significant loss of smell is a very big indicator of type 2 inflammation. You could do a smell test, or if they tell you, we in US don't do more tests for smell in a regular basis other than clinical trials. And another criteria that would suggest type 2 inflammation often in patient with polyp would be presence of asthma, and asthma needing regular inhaled corticosteroid.
All right, so again, I'm Christine Franzese. I'm an otolaryngologist. I do sinus surgery, and we're going to talk about some of the practical considerations in the use of these biologics or monoclonal antibodies for chronic sinusitis with nasal polyps. What do you need to know? What does everybody need to know? Well, so we're going to dig into patient care, and thank you for that patient case. There's a lot going on there.
Yeah, she is quite an interesting one. There was a lot of hands on deck for that.
Right. So you actually, in your patient case, talked about all these different specialties. Like here you see the circle of life here for this patient, or the circle of confusion, because you'll notice with a lot of these patients, they seem to have multiple comorbidities.
Yes, absolutely. And I think that's where, as an advanced practice provider, we're really uniquely situated, where we can kind of serve as a middle ground for patients, where I am fortunate to be able to have the time where when we're talking about something like a respiratory biologic, we can kind of serve as an interpreter almost for all these different specialties, and working at an academic center where we collaborate a lot in research, I'll reach out to ENT and say, what do you think about starting a biologic for this patient? And we'll reach out to pulmonary if there's a pulmonologist on board. And often, and it's completely optional, but we do offer it to our patients to do a teaching visit. And that way we can kind of talk through anything finicky and or even talk about the prior authorization process. Like, please pick up the phone if the specialty pharmacy is calling you. That is not a scam phone call. You have to pick it up and confirm your address. But it's a nice way to kind of make sense of this kind of circle of a lot of different hands on deck involved, and kind of serve as the main point of contact for patients and build that relationship there.
And I think that's so important that you emphasize that patients really need some time to hear this information again, because there's 3 of these that are FDA approved. There will be more coming. It's a lot of information that these patients are getting from different physicians. We don't always talk on their level. And then there's also their other doctor that they go to, Dr. Google, which tells them like all kinds of things. So it's really helpful for us to work as a team to put this all together. So when you're talking about these different kind of therapies and bringing it together for the patient, you want to invite them to engage in this shared decision making. Now, some of them won't. There are still some that are going to be like, I just had one the other day. It was like, you are my doctor. And this patient actually was a doctor. He's like, I want you to be my doctor. Just tell me what to do. And there are others that really want to have a lot of active say in what they do. So it's really important for all of the patients, even if they want you to be their doctor, I will still tell them all their different options, give them information on the benefits and risks that involve with each, particularly if it involves like complicated insurance stuff, provide them with the ways to evaluate these different options, talk about their goals for treatments, their expectations, because it's really important to manage expectations. We don't really have a cure for this yet, and I am not a magician. So we have to manage this with our patients and then kind of assist them in doing that, because they will need help. There will be struggles. So when we're engaging in shared decision making, we're going to talk about different medications. We just went over intranasal corticosteroids, exhaled delivery systems, in addition to these monoclonal antibodies, different surgical options. Has the patient ever had surgery before? And we'll frequently in ENT talk about, have they had good surgery? And that isn't always easy to tell. If you are not sure and you don't work with an ENT, here's a close guide. If someone says they had nasal polyp surgery and it took them less than an hour, they probably didn't really have what we would consider typical functional endoscopic sinus surgery. An average full good fest will take about 2.5 to 3 hours. Comorbidities, they're going to have asthma, potentially other issues, allergies. Review their symptoms, because symptoms are really more important than polyp size. If the patient's polyps shrink a little bit, but they're still miserable, then that's really important to us, and we need to adapt our treatment plan for that. Their quality of life, smell is a big issue with that, as well as sleep. You don't realize how disrupted your sleep cycle can be when you can't breathe through your nose, as well as adherence. Is this something that they can do all the time, daily, every other week, once a month? Kind of what are they willing to buy into? And then the cost. That is a big option. In this economy, with the price of eggs, you need to tell them how many dozen eggs does this nasal spray cost? So you'd get into this shared decision making, you talk about all their goals, their expectations. So we're going to talk now about some of the different options we have. So the first one is called dupilumab. These were the first 2 trials that came out. They were both FDA phase 3 trials. This data is all adult data. Now you'll notice that dupilumab is approved down to the age of 12, but for the data for sinus 24 and 52, these are all 18 years or up. For these patients, they were not required to have surgery, but if you had surgery, you're allowed to enter, but you had to have at least, the use of systemic corticosteroids within the last 2 years, or contraindications to such, or contraindications to surgery. For those people that were enrolled for the first trial, Sinus 24, you got this medication for 6 months, and then they followed you after that. And then for the other trial, Sinus 52, you got it for a full year. And you'll notice notice on both these sides, so here we have the nasal polyp score, okay, and then nasal congestion score. And you'll notice pretty early, you can see this separation between the treatment group from the placebo group, and they had a significant statistical difference between these two in nasal polyp size, and even pretty quickly at about 4 weeks. You'll notice there's another arm here, dupilumab 300 milligrams. Around 6 months into this trial, they went to every 4 weeks. Now, that arm did not get approved by the FDA, so we use dupilumab every 2 weeks on label. You'll also see, though, this same separation pretty early in the nasal congestion score. Now, that was a score between 0 and 3, and it's sort of weird to see these negative numbers along the side. What that means is the score is getting better. The higher your score is, the worse it is. The lower your score, the lower the number, the better you are, the better you're feeling. So for both nasal polyp score and nasal congestion score, we saw statistically significant improvement in these trials, leading to the approval of dupilumab 300 milligrams every 2 weeks. This is some data that shows you that during these trials, patients were allowed to have nasal polyp surgery. They were also allowed to get systemic corticosteroids, because think about how miserable this would be if you weren't having a great response and you couldn't have rescue treatments. But these patients weren't booted out of these trials. However, they did actually measure like the difference between each arm and whether who ended up needing it most or more between the placebo and the dupilumab. And you can see there is a significant difference between these two arms, and that those in the treatment group had less surgery, less steroid use, and that's really important for our patients because we understand that there is a lifetime cumulative risk with the use of steroids, and that is a lifetime cumulative risk that doesn't go away. So it's something that we need to be very cognizant of. One of the things your patients may ask you when you're starting one of these medications is, how long do we have to be on this? You know, will I be on this forever? And it's something I frequently get asked, like, when do you assess? How do you know that it's working? So this is the euphoria criteria, which Dr. Peters kind of touched on a little bit, that euphoria, so the European Forum for Research in Respiratory Asthma and Allergy. Don't confuse it with the euphoria on the HBO Max with Zendaya. Very different audience, both involve pharmaceuticals, but like, no, you want to go to this is the data you want to see. And so they've tried to, like, once you initiate this, how do we know it's working? So there's 5 different criteria. One is, you know, any change in nasal polyp size. Have you reduced the need for systemic corticosteroids? So we should track like how frequently patients are getting these. Improvement in quality of life. So this is where your SNOT-22 scores or other quality of life scores come into play. Improved sense of smell. You can do a smell test, but many people will tell you, and I use monoclonal antibodies in my practice. I didn't always believe people at first until I saw the data, but in using them, some of my patients would be like, you know, I started to smell within the first week. In fact, I had a father complain to me because he was on dirty diaper duty, and he could smell now, and he did not like that. So, so this can be a big quality of life thing, and then the impact on their comorbidities, their asthma, their atopic dermatitis, their eosinophilic esophagitis, whatever other comorbidities they have, and whether they have an excellent response, good response, poor, moderate. And you can see generally, Euphoria recommends at 6 months you do your evaluation, and if they are not having a response, consider discontinuing treatment, and then you can reevaluate at a year and discontinue treatment. Then I will let you know. I am America, okay, so I'm American. I don't agree with these European recommendations, and mainly from the data, and we're gonna go over a little more, so this is my own personal bias. I actually will assess people after 3 to 4 months. You'll see from the data, when these work, it's amazing. Like, they don't have to disappear. They don't have to be completely asymptomatic, but you'll really see significant change, and your patients, even more important, will tell you. So if I'm not getting anything at 3 to 4 months, I actually start to consider this, but if you have a question that comes up on a test that has this, the answer is 6 months, okay? So here's some data about, well, does this last? Because that's another thing. Your patients are going to want to know, am I going to get immune to this medication? Is this, do I have to worry about that? Like you'll hear this about antihistamines. I have to switch up my antihistamines every 6 months. They're concerned if this works for them, is this going to wear off or something? And so here's some data from Germany that shows the use of dupilumab over 3 years. So this is dupilumab subcutaneous every 2 weeks. And you'll see during this 36 months or 3 years course, people had great response to their nasal polyp score, their SNOT-22 score, so right here. And this score goes from 0 to 110. Anything over 50 is considered severe. So you can see these people were at the severe level, and boy, they had a lot of improvement, which lasted over those 3 years. And then this is a specific smell inventory test. It's different from the UPSIT. It's a culturally, it crosses more cultures, like the dirty diaper smell. That's kind of a universal smell, but there are some other smells that aren't and can be culture specific. So this is a test that's more like universal for measuring sense of smell. And then you can see the euphoria response, where pretty much everybody had almost a good to excellent. There are a few that had poor to moderate. And then sleep disturbance. So Dr. Peters introduced this like the pre-data. This is the follow-up data. After these patients were introduced to dupilumab every 2 weeks, you can see that they had improvement in their daytime sleepiness scores, that they had improvement in their insomnia index, as well as their altered sleep quality. So they had a lot of improvement. That can be huge for your patients. We're going to touch on omalizumab. That's another FDA-approved medication. The trials for that were Polyp 1 and Polyp 2. They were also adults only. Similar to dupilumab, there was not a requirement to have surgery, but you had to have exposure to systemic corticosteroids within the last year or two before enrollment, or a contraindication to it. These trials included 6 months on the drug, and then you'll notice there's this what's called open label treatment extension with everybody, which is really nice, whether you were on the placebo or if you had drug, you could continue it. And so people on the placebo, you can see there's a significant change in their nasal polyp score, and then everybody had improvement while everybody's on the drug. So this isn't a placebo group anymore. People are getting active drug. And then there was a safety follow-up period where no one got the drug, and you can see similar to the dupilumab data, there's a bit of backsliding here. But overall, you can see statistically significant improvement in their nasal polyp score. We see the same in their nasal congestion score over time. We see a really early change in the congestion score for this, and then improvement when everybody's on the drug, and then on the safety follow-up, some backsliding, which is pretty typical of these trials. This is the other one, mepolizumab. Now, this had a synapse trial. This is a very large trial. This was the one that's a little bit different because everybody was required to have surgery, sinus surgery, so everybody had surgery, and there is another requirement that it had to be within the last 10 years, and that's really important because sinus surgery has changed a lot within the last 10 years. Techniques, success rates have really evolved, so that sets this apart. You can see that while patients were on the drug, you have the placebo group here, the treatment group here. Again, there was a statistically significant improvement in the nasal polyp score. Again, you can see that, again, pretty early over time. And then this was when the follow-up period when everybody is off drugs, so the treatment group is getting no drug. And you can see there's a relatively good maintenance of that reduction in nasal polyp score, despite the fact that the blood eosinophils return to their baseline. So overall, kind of in summary, we've got these 3 new monoclonal antibody weapons that we can use to help us treat patients. So omalizumab, there was statistically significant improvements in patients' clinical and reported outcomes. It was more effective than a placebo, even in patients with high eosinophil levels. Dupilumab, again, significant improvements across all outcomes, significant reduction in repeat need for sinus surgery, as well as oral corticosteroid use or systemic corticosteroid use. And that efficacy was independent of eosinophil level or IgE levels or comorbidities. And then mepolizumab significantly reduced the need for surgery. It also met statistical significance, and it has showed improvement in symptom severity regardless of comorbidities or the presence of AERD. So let's bring this case home.
So, visiting our friend Rose again. So she definitely needed some help, especially when our traditional treatment options were not working so well. We had kind of maximized our options in general across the board. So we decided to initiate treatment with dupilumab. And within 3 months of starting treatment, so I also agree that I can almost tell as soon as I walk into the room, before a patient even says anything, they just have a sense about them where I can tell something's different, because it's just such a quality of life component when you're able to breathe for the first and foremost, and also to smell and taste. It has such a social component, being able to go out to dinner with your spouse, or for safety purposes, being able to smell smoke in the home. We have patients that work as a chef or as a firefighter, where that definitely affects your career in that sense. But with Rose, she came back. Her FEV1 went up to 80% of predicted 3 months after starting treatment. Her eosinophil count went down to 600. And then her polyp score was 1 out of 1 bilaterally on our exam. 6 months post-op, she only had mild polypoid edema, and she had regained her sense of smell completely. She was no longer requiring any oral corticosteroids. That includes both inhaled corticosteroids or prednisone tapers. So this patient who was requiring frequent hospital visits for asthma exacerbations, including an ICU visit, which, by the way, at a follow-up visit, turns out she might have taken ibuprofen before that ICU admission, which, now in hindsight that we know that she has a diagnosis of AERD makes sense, but that often happens when we are talking to patients. We'll find that, as we get that diagnosis, maybe some of those prior hospitalizations or those severe asthma exacerbations may have been linked to NSAIDs previously. But as of now, this patient, I first met her years ago. She has not had a single surgery, and she has been on Dupixent for 4 years. She has no polyps on exam. I just saw her last month. She still has her sense of smell and taste completely intact. She is not on any inhaled corticosteroids for asthma. She uses her rescue inhaler as needed and is doing remarkably well. She uses intranasal steroids as needed as well. And she saw ENT last month, and they did not see anything on exam.
So now we're going to touch on some of the future potential options we have. So the Everest trial, this is really unique. You don't see head-to-head trials of pharmaceutical agents often. So the Everest trial is actually dupilumab versus omalizumab in patients with severe asthma and chronic sinusitis with nasal polyposis. We actually were a site for this. Is a very difficult trial to enroll in because of the severity for both things to be needed. It is close to enrollment. Its anticipated completion date, as you can already see. Now, the data has not been reported yet, but I think everybody is kind of eagerly awaiting what the results of this trial are going to be. But that's very exciting. We also have 2 new agents potentially on the horizon that have already reported their results to meetings, but they haven't been published yet. So depemokimab is from the ANCHOR trial, ANCHOR 1 and 2. This is a every 6 months injection. That's kind of nice. It met both of its endpoints, its primary endpoints, and an improved nasal polyp score at week 52. Again, it's announced its results. It hasn't been published yet, awaiting FDA approval, but potentially may have an every 6-month option. And then tezepelumab. So depemokimab is an anti-IL-5. Tezepelumab is an anti-TSLP. Those trials were the Waypoint trials. They also announced statistically significant improvements in their co-primary endpoints with meaningful and significant reduction in nasal polyp size. That's a once-a-month injection. So again, 2 more things, which is great. It's great for us to have options. So in summary, we're going to wrap this all up, and thank you all for your attention. Chronic sinusitis with nasal polyposis is associated with a lot of symptom burden, really decreased quality of life for your patients. The condition can be refractory. Despite our best efforts, despite your patient being compliant, Sometimes things just don't work out how we want them to for our patients, and our traditional medical and surgical treatments fail. It is generally characterized by type 2 inflammation, and asthma is a common comorbidity, which you will see with your patients. We now have these directed monoclonal antibody therapies. We've got 3 approved now, and probably 2 more on the horizon. These therapies can significantly reduce nasal polyp size, improve quality of life and congestion scores, and really help with that burden of disease in our patients. And then we talked about the considerations for whether a patient is a candidate or not and the different approaches to treatment. So this is our question and answer session. We do have some questions available, so I'm going to take one now. How do you approach care with a patient that reports no symptoms, but on physical exam, she had an incidental finding on recurrent polyps following functional endoscopic sinus surgery or FES in bilateral maxillaries and anterior ethmoids? I'll take a moment to ask. So this is a patient we have that had sinus surgery, maybe has some incidental recurrent polyps, but they report no symptoms. I'll go last. I'll give you the surgeon's perspective.
Do you want me to go ahead?
Yeah, would you like?
You know, this is actually a really good question, and we see this often. And as you had mentioned earlier, Christine, these biologics help symptoms tremendously. They shrink polyps, but as you noticed on those figures, they don't completely get rid of polyps in everyone. So if someone has an incident polyp and is doing okay, I just follow them along. If their polyps are large, then chances are symptoms will come back. And I may tell them if they're not using topical steroids to get going on their sinus steroid rinses or EDS flu. If you look at the Euphoria paper with Fokins as the first author, where we discuss remission, where we say people have no symptoms, no steroids for a year, we say a polyp size up to 1 may be present. It may be that it's not bothering them. Why do anything else?
Yeah, I would say from the surgeon's perspective, patients can live in symbiosis with small to medium polyps and be asymptomatic or minimally symptomatic and be just fine. As a surgeon, I would not operate on that patient, and I would not recommend any surgeon do that, because we are here to make people better. And if they're actually doing really well and they don't have symptoms, they don't need surgery, they can continue with whatever treatment you're using. So that's a patient that's okay. So definitely, as far as a surgeon goes, I would not operate. Like little polyps, or even just medium-sized one. If they're not bothersome and they're not causing problems, that's fine. So what is the course of aspirin desensitization? Is it lifelong, or does it have an end date? And why not try that prior to biologics in an aspirin-sensitive patient?
Do you want to answer that first?
Sure.
Or do you want me
I will
to?
try and make this
You
as
answer, and then
succinct
we
as
can add-
possible.
I can add
So,
on.
the answer is it's not one size fits all, unfortunately. So it depends. It is not necessarily lifelong. It depends on whether or not it works. So if it's working well and things are going well, then there's no need to stop it. We can continue on. And we continue on until we find something better, or there are adverse effects where we need to stop. Otherwise, if it's not working, we go on to something else. Why not try that prior to biologics in an aspirin-sensitive patients? We have, especially with my patient, we certainly did, and unfortunately, in about 60% of patients, it is not, or in 60% of patients, it does work quite well. We unfortunately can't predict who falls into that category. And there are some other reasons that, depending on where we meet the patient at that time, where if someone has whopping polyps on both sides, aspirin desensitization only really works as effectively as it can when we meet them immediately post-op. And so I am not going to make someone wait to book surgery or wait to meet ENT, then book surgery, then come schedule an appointment with me to do a desensitization when alternatively we can get them started. It feels a little bit cruel.
So
I
I'm
think
gonna.
you answered that very well. The only thing I will say, and you mentioned that as well, aspirin desensitization is a true desensitization. If someone stops it for more than 48 to 72 hours, you have to restart it. The doses of aspirin we have to do desensitization again to restart it. And the dose of aspirin that we start after desensitization is huge. It's 650 twice a day. Think about that. Then we leave them on it for a month to 2 months and then go to 650. Most people have to, for best benefit, stay on high dose, so 325 twice a day or so. There's a paper that was published by a guy named Paul Oykman, O-Y-K-H-M-A-N. If you want to look at it, they're from McMaster's in Canada. And they did a meta-analysis and a systematic review comparing biologics to aspirin desensitization. The biologics work well. Aspirin in many works well too. But the one that is a little red box looking at adverse effects, so the one that's associated with adverse effects is unfortunately aspirin desensitization. So GI intolerance can happen. I live in the city of Chicago where we have ice and snow a lot. People can fall and hit their heads. So you worry about those side effects. That is something before biologics we didn't have, so we used a lot of aspirin desens. Now I would think that your center, my center, we put them on biologics first.
Also with procedures, if anyone's going to surgery, that means that they have to repeat desensitization, where they have to stop and then we repeat it, or pregnancy is also a conversation that comes up a lot as well. So there's a lot to consider where that was all factor into our decision making.
Yeah, we have a lot of questions. This is great. I'm gonna skip around. We're gonna pick one. So how do you pick which biologic to use? That's one of our questions. Who would like to answer first? And if no one, how do you pick which biologic?
I mean, I'm happy to answer that, and then I think we probably think similarly a lot. There is practice guidelines that the Joint Task Force from American Academy of Allergy, Asthma, and Immunology, which we would call Quad AI, and American College of Allergy, Asthma, and Immunology, we met for 2 years. These were allergists, ENTs, and we put the guidelines out on how to decide which biologic to use, when to use it. And there's a really good table, and we used Paul's paper, and you could see it looks at what are outcomes important to patients, such as smell, congestion, adverse effects, and what are outcomes that we need to get drugs approved. So sinus CT scan, polyp size. We compare all the different biologics, and we compare aspirin desensitization. Dark green shows the most benefit. Among the 3 that are approved currently, dupilumab is the best when you look at the evidence, but the others work too. So if you start someone on dupilumab because that seems to be most effective, if they have side effects or they're the small percent it doesn't work well on, you could consider the other 2. You could consider aspirin desens. You know, we have one that the waypoint from tezepelumab looks very promising. So I think our guidelines are a really good way of looking and deciding. We are developing the joint ENT allergy guidelines also, so that'll help.
Yeah, I agree. I think we're very similar in that way. I think the other thing that's really important is to talk to your patients. What is bothering them the most? What is your most problematic symptom? Where, if I have a patient where asthma is more bothersome, maybe that's guiding my decision making a little bit more. Where if someone's struggling more with polyps or sense of smell, that's also going to kind of sway my decision one way or the other as well.
I will say I agree with all that. I use all 3 of these in my practice for chronic sinusitis with nasal polyps. I found them all, that in the right patient, they can be very helpful. People ask, what's my favorite biomarker to choose which one to start on? And I'll be honest, my biomarker, it's not my favorite, but it's insurance status. Like, that is a practical fact of life that you will have to face using these medications, and insurance will frequently make the choice for you even when you don't want to, so that is something to consider as well. How long would you keep patients on steroid rinses while on biologic therapy? I'm going to answer that one. Their insurance will probably want them to be on intranasal corticosteroid sprays during that treatment because it's considered add-on therapy. So you can continue the rinses, but I'll be honest, this is sort of like asthmatics. Your patients may stop them and not tell you. That frequently happens. But there's no requirement to, but if patients are still having polypoid change or polyps or symptoms, I would continue the steroid rinses while they're on the biologic. How often do you do a sinus CAT scan while on a biologic? Do you do nasal endoscopy?
Oh, endoscopy?
yeah,
I
nasal
work in
endoscopy.
sinus center,
Yeah.
so I'm lucky to work with an ENT where we have an endoscopy. In my sinus center, I do it. In my regular allergy clinic, I don't do endoscopy. But we don't. We do a CT when we first diagnose them. If they're doing better, like you said, their smell's back, their congestion's better, why give them radiation if you don't need it? No, we don't do repeat.
If you're able to do endoscopy, that would be my preference. If you don't have the ability to do so, you may have to do it, but I find, the sinus CAT scans, they're like 50 shades of gray. You can't really tell exactly what's polyp all the time and what's just thick mucus, and so it may be a little difficult to use that for an assessment, but I'm going to say, if worst comes to worst, if your insurance may want some assessment once a year, and so I would say probably maybe once a year, but if you could at all do endoscopy, I would strongly encourage you to use nasal endoscopy for monitoring and assessment. In patients with nasal polyps who have failed other medical treatments, is it generally considered better to do surgery first and then add a biologic, or to start with a biologic and then consider surgery? That's an interesting question. That's actually really good, and it's gotten a lot of discussion going in the ENT world. I generally will do surgery first and see the results, and if it is necessary or not, because as the Daconda trial was quoted up here in these slides, there's a 40% recurrence rate, but 60% do fine after surgery, may not need this. However, we've also talked about how steroids can cause lifelong, dose-dependent cumulative effects, and a lot of surgeons will do a week of steroids prior to polyp surgery. Some surgeons have talked about, well, maybe we should initiate a biologic instead of doing steroids to avoid that, and then do the surgery to reduce operative time and blood loss. So there isn't one right answer to this. It's actually kind of controversial, and I don't think anybody knows the right answer, but certainly people are really looking at it.
I agree. This is where shared decision-making helps. And if they have AERD, they have severe asthma, I would say, yeah, you need a biologic and probably surgery. When you think of costs and you think of lifelong or not, most people don't need lifelong. I think most of us agree that one surgery is the way to start, because people may do just fine with surgery and topical steroid rinses. In fact, that's why Euphoria actually has it, as it's in everyone who's had one surgery.
So I want to thank everybody for coming. Thank you for all your questions.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent medical education grant from Regeneron Pharmaceuticals Incorporated and Sanofi. To access all materials for this activity, visit peerview.com/NFR860.